All right, good morning, everybody. We're going to go ahead and get started for the sake of time. We have a lot to cover today, and so I want to make sure that we have an opportunity to get through everything. My name is Candace Bailey, and I am the HCBS Division Director within the Office of Community Living. And today we are going to talk some more about the Nurse Assessor Program and really looking for a lot of feedback from folks today. So please get ready. Next slide, please. All right. So just a couple of little reminders. We are actually recording this meeting, so please refrain from sharing any protected health information. If any protected health information is shared, we actually will not be able to post the recording online, which would be a big disservice for all those folks that are not actually able to join us today. Please use the chat feature for questions. We're going to do our absolute best to answer your questions. As you know, sometimes there are just far too many for us to be able to get to. And so we do actually capture every single question. We put it in our listening logs, respond to each of them, and post it online. And so if we don't get to your question today, my sincere apologies. There's just only so much time and so much ability for us, but we will do our very best to get to them. The slides are posted online. Folks will actually go ahead and put the link in the chat for me. I know because they do really good at that. So that you all can have access to them. If you're listening to the phone and when we get to a point where we're asking for feedback, you can press *6 to unmute your phone, and you can press *9 to raise your hand so that we can then call on you once it's your turn. If you need the closed captioning, that is an available option. We are actually not using AI note takers. It creates a lot of issues when things get posted online. And so if there is an AI note taker, it has been removed. Please use the closed captioning function that is available to you via Google. And then any additional questions or comments, you guys can access our Nurse Assessor website. We have all the information posted there, past meetings, dates for future meetings, listening logs, all kinds of information on that site. So please frequent that. Please go ahead and bookmark it, as there is going to be a lot more information posted from now until probably August. So next slide, please. All right, so let's go ahead and ground ourselves in our mission. It is improving healthcare equity, access, and outcomes for the people we serve while saving Coloradans money on healthcare and driving value for Colorado. Next slide, please. Okay, the meeting purpose. So it's really important today. We are hoping to really provide some additional information around some timelines and then engage and receive your feedback around a couple of key components with the Nurse Assessor, which is an OCL priority project. Next slide, please. Here's the list of items that we're going to go through today. We'll recap our previous meeting, our last one that we conducted. We'll go through some of the resources that are available. We're going to go through the timeline. There's a lot of questions around how long Telgen has to conduct a variety of different steps within the process. We're going to go through all that today. And yes, it will all be posted online. These slides are posted online, but we'll also make sure the timeline is very easily accessible online as well. And then we're going to go through the criteria. This is a really key component where we are looking to get your feedback today so that we can finalize the criteria. So we're looking at how are we going to set the criteria. So let me be clear, none of this is final. We are seeking your feedback today to make this criteria final for Telgen to be able to use starting in July. So the criteria will be the in-person versus virtual, intake, express, and expedited assessments, and those three things there. And then again, we really need your feedback so that we can have this criteria finalized for our vendor to use. All right, next slide, please. Okay, so recap of our last meeting. So we went over, the last one was primarily focused on health maintenance activities and the intersection and how that's going to work with the assessment and all of the information. We answered a lot of questions around timelines there, the direct care calculator. We went through and provided the examples of the skilled tasks, the prior authorization, and we went through some pretty clear case examples. The biggest piece here is really providing the information around the reason why health maintenance activities is included in this is, one, because it is necessary in order for us to have community first choice be able to be launched with health maintenance activities. It's also a skilled care service. In our slides, we listed off all the tasks that can be provided under health maintenance activities. And outside of around 3 of them, which one of them would be like wound care, they were identical. Health maintenance activities are skilled care tasks. The acuity assessment and the nurse assessor conducting the assessment is looking at skilled care needs in those tasks. And so it makes sense to put all skilled care tasks together under the assessment. Again, the prior authorization still goes through the case management agencies, and they still conduct that. And if the recommendation letter from the nurse assessor does not provide enough time, and there is a clear, justifiable, and documented reason why the case manager needs to authorize additional hours, that is allowable. And then we walked through some case examples. Here's a link to the webinar from that meeting. The listening log from that meeting isn't quite posted yet. There's a lot of comments, and it takes us a while to get through every single one and provide a response, but that will be coming very shortly. And then again, the nurse assessor and skilled care acuity assessment website, lots and lots and lots of information, a lot of detailed information around with the assessment on there, the acuity assessment, the scoring criteria, the formulas, all of that is online. All of that is posted. There's lots of one-pagers and videos that will walk you through how it works. So I highly encourage you to take a look at those so you can fully understand. All right, next slide, please. Okay, so one of the big important pieces that we are really excited to now have that we can share with you all is the timeline. So what does it look like from referrals to the assessment? How long does Telegen have? So we are asking for referrals to be submitted for up to 60 days before the PAR expires, with around a recommended window of around 30 to 45 days. And that's to make sure that when the information that is provided for the intake call, it's as close to the member's most current needs as possible. It's okay if it's longer than that. That's just kind of an ideal window. And so the referrals will come in from home health agencies that are looking to get PARs going, or the case managers who are conducting the CSRs or continued stay reviews for health maintenance activities for those CSRs September 1st and forward. Take a quick little pause. I noticed we have somebody that's not muted on the phone. If you could please make sure you are muted. That way we prevent any background noise. It's really hard to hear, even with just a little bit of background noise. So just a little reminder there. Okay, so that's the referral timeline. We're asking for folks to submit those referrals in those timelines within 1 business day of Telegen receiving the nurse assessor referral. So within 1 business day of Telegen receiving that referral, they will reach out to the member called the intake call. They will begin that contact and continue that contact every single day for 5 days. The assessment must then, once they reach the member, so once they have, or the representative, it could be a family member, once they reach them, the assessment must be scheduled within 7 days from when they reach that member. The 7-day window can be pushed out if requested by the member. So let's say within that week, you just aren't available. You just don't have time. That's okay. You can request it to go out further. Telegen just cannot request it to go out further. So our vendor. After the assessment is completed, Telegen then has 48 hours to complete the recommendation letter. So there's some really big timelines, some really important pieces for everybody to see. I know these are things we've been talking about. We've been working on finalizing them. There they are. Very exciting. Yes, all on the website as well, or will be. This is on the website, but we'll pull it out separate as well. Next slide, please. Oh, go ahead, Cassie.
Candace, I just want to, there was some confusion at the last meeting, and another question in the chat. The contract does use language like business hours, but really what we're talking about is days. And so when we say like 24 business hours, are we really talking 3 days of operating business, or are we really just talking about 1 day overnight? Can you just clarify what that means?
Yes, so thank you so much. So we switched from hours to days to hopefully provide it a little bit more, make it a little bit more clear here that we are talking days. So if we say 24 business hours, it's 1 business day. And so it's not that they have 24 hours. That is just the 9 to 5 traditional working time. It's one day. And so it's, if they get a referral in on a Tuesday, they must contact or attempt to contact, because not everybody can be reached right away. They must attempt to contact the member by Wednesday, the very next day. If it's on a Friday, they do then have until Monday because of the weekend, but we are actually talking about days, not 9 to 5 hours. So hopefully that helps. Thank you for pointing that out, Cassie. This is a little visual of the timeline that is easier sometimes to see rather than just a stack of text to show you the flow and the hours and the days. Again, it's the same idea. It's just laid out into a more of a visual format.
Is there any way you could make that any bigger, please?
I cannot, but we can look to make sure that I know that it'll be accessible online, because everything online has to be accessible.
It is. And Shannon, if you hover over and apologies for the smaller font, but if you hover over your screen, there should be in the bottom right corner of the screen sharing part, a zoom button. So you could zoom in on your individual screen.
That's okay. I was just trying to respond to some of the chat. Thank you.
Yeah. All right, next slide, please. Okay, so some important factors that can affect what we call the turnaround time. It's a long phrase, so we abbreviated it here. Some of those are going to be successfully answered intake calls. So if a member cannot be reached within that one day, it's going to be longer before the assessment is completed. Telgen will continue to contact a member every single day. So they will make a phone call every single day for up to 5 business days. Again, not talking hours. 5 business days after the referral is made. If the member is not able to be reached, then they will actually have to close the referral. A letter will be sent. There's some more information on that in the next coming slides. But the timeliness for when Telgen is able to make contact with a member can affect the overall timeline. It's an important piece to keep in mind. And then the scheduling. The member may also actually push out the assessment for up to 15 business days to accommodate their own schedule. So if they need to push it out, again, that's going to push out when they get the recommendation letter. So those are just some important factors to keep in mind as we are looking at all those timelines. I think Cassie, do you want to take questions now? Or do you want me to go through the referral piece?
There's some question of how many times, is there like a maximum amount of times they might call, like we'll call you 20 times, whatever that may be. And I see Katie's going to come in with an answer. And then the other question of, is it only via voice type of phone, or is it email or text? Thanks, Katie.
Okay, I'll let you tackle those. Thank you so much.
So they will reach out multiple times a day from whatever route of communication was selected as a preference when they submit the referral. Important to know that a lot of these specific details are still being worked out. So, and remember, this is a new process here in Colorado. And then second, I want to just remind, especially the home health agencies, when you're submitting a referral to the nurse assessor for one of your members that you care for, make sure that you touch base with them and remind them that they are going to be receiving a phone call, potentially from a number that has never called their phone. And some phones have settings to send those types of calls directly to voicemail, which is completely appropriate, but just make them aware that they are going to be receiving a phone call from an unknown number.
Thank you, Katie, very much. And I would echo that for the home health agencies and also the case managers, if they are submitting a referral as well, to ensure that the member knows that they will be receiving that call so that they can be expecting it. It will speed up that timeline quite a bit. Cassie, are there other questions on the timeline specifically? I know there's some referral questions coming in, but that's my next couple
we'll
of slides.
hold tight on those. I think that's it for timeline at this point.
Okay. All right, let's go to our next slide, please. Okay, so step one of the process. So obviously there's multiple steps within the process itself. Step one is the referral. And so this can actually be completed via the website or phone. So Telgen has a system where somebody can go in and submit an online referral, or they can call. There's multiple ways that a referral can be submitted. Then Telgen will contact the member within 1 business day of the request. And again, to Katie's point, that will be based off of the way that they reach out to the member. It will be based off of the chosen preferred contact method. So if the referral is submitted and said this member would prefer to be contacted via phone, they will call them. If they say they prefer to be contacted, and my apologies, there's a delivery, my dog is now barking. Wouldn't be a Tuesday otherwise, right? If they choose that the member would prefer to be contacted via email, they will reach out that way. So it's based off of how it is selected within the system itself. Next slide, please. Who makes the referral? So this is important, and I'm so sorry about my dog. Of course. Okay, so for health maintenance activities, the case management agency is the one who is really going to be making the referral, because they are the ones that coordinate those services and they conduct the prior authorization. For long-term home health and private duty nursing, the home health agency is the one who's going to be making the referral. If none of the above apply, really a referral can come from anybody. It can come from a member, a family member, the legal representative, physician, a lab practitioner, social worker, discharge planner, or the member can actually submit a referral on their own if they would like. I did see a question come in around how is the member going to know if a referral is submitted to them? I sure hope that anybody that submits a referral lets the member know. So case management agency, if somebody has health maintenance activities and you are submitting a referral, you need to let the member know that you have done this step in this process. The same for the home health agencies. 1, again, to notify the member that they will be receiving a call, and 2, to let them know that this has been done, this important step. Next slide, please. Another visual, we like ourselves some visuals because I know it helps me see the flow a little bit better. So these are some common types of referrals. Again, common types, there's always those outliers and we just can't put every single instance on a slide. But you have your case management agency or home health agency referral. When you have a hospital discharge or a new member, then the referral will be made. You go through this process around whether there's immediate needs or not. And then whether or not it's a hospital discharge and so they need somebody out really quick, or it's more of a continued stay. Member receiving current services, there's a little bit longer time because the services are in place, the PAR is still in place, nothing has expired. The need is less urgent than if it's brand new, we're looking for a discharge and things like that. So there's just a flow of a couple of types of referrals. With that, I'm going to pause and ask Cassie to go through a couple of the questions for me.
Yeah, I think the main question I've got here is, Candace, what if I'm a member that receives long-term home health and health maintenance activities? I have a home health agency and a case manager, or I'm discharging from the hospital and I've also got a home health agency I'm working with. What if there's duplicative referrals? What happens then?
Yeah, so thank you so much. Great question. The system actually will check for that. So Telgen has it in their system to make sure that to check for duplicative referral, so they are not calling a member 4 different times for the exact same needs there. And then the nice thing about the nurse assessor is you could have the 3 different services, and rather than having 3 different assessments and 3 different referrals, the nurse is going to go out and conduct 1 assessment at one time, which will really streamline things for the member specifically. What other questions do we have, Cassie?
I think that, go ahead, Irina. I think that was it really for the referral process at this point. Yeah.
Thank you, guys. Good morning. Apologize if I kind of running ahead a little bit with my question, but it seems like lots of examples that we've been covering through the past meetings and to date is based on situation when the patient is an existing patient. Can we go through maybe an example one more time when it's a brand new referral for a home health, long-term home health, and maybe CNA only case, which we cannot go through the acute episode for Medicaid for those cases. We have to go into long-term right away. So how would that work if we have 10 days, excuse me, to submit the PAR to a Centra from the start of care, but the referral process and then assessment process may be outside of that 10-day window. So can you walk us through a little bit of, for example, like that?
Yeah, so we're going to go through a little bit more around like the intake call. I think when we were talking specific examples, we will get into a lot of those during the training, which is coming up very soon, where we can walk through, here is an intake, a brand new case that is looking for private duty nursing only, which doesn't have acute care. Here is one that is looking for CNA. Here's one that has all 3 services, and we will walk through each of those in that process flow in the training that we are building that will be provided very soon, actually by next month, because next month is June, which still blows my mind. But so those are coming. I don't have those specific examples outlined for today, but we can certainly make sure that we build those in for the future. Cassie?
Sure, that would be great. Yeah, because I think it will relieve anxiety of lots of providers, again, knowing how to act with the initial referral, still maintaining the compliance, regulatory compliance, within 48 hours,
Yep.
from the start of care, from the order, you know what I mean? Just really would be helpful to know the initial steps
For
to
sure.
initial referral. Thank you. Mhm.
And Irene, I was just going to mention that I'm not sure what the situations you're describing entirely are, but there is certainly the possibility that acute home health is applicable and allowable in those cases if they're discharging from the hospital, if there is any kind of exacerbation or a new issue. So in a lot of those cases, acute home health can be in place, and then that kind of alleviates that timeline a little bit.
Correct. I mean, there's definitely cases that will be qualified for acute home health, but there's also cases that do not. And so that would be a good example to review.
Perfect.
Thank
Okay.
you. Thank you. Mhm.
We've noted that so that we can make sure that we walk through that. I really appreciate that feedback. That'll be important for us to make sure we go through. All right, let's move on because I'm really excited to get into the meat of, well, it's all important. But some of this is going to take a little bit longer because we're seeking some very specific feedback from you all so that we can finalize our processes. So step 2 of the process, the intake call. So we had the referral, everything's great. Now we're moving on to the intake call. The member will be contacted within 1 business day after the referral is received. So if it comes in on Monday, they will be called by Tuesday. If it comes in on Friday, they'll be called by Monday. 1 business day within from when the referral is received. Telgen may contact the member or representative via phone, text, or email, as we mentioned, as requested within the referral. So in the referral, it will have the information of what is the best way for Telgen to reach the member or the member's representative. And that is the path that they will choose. If Telgen is not able to reach the member, they will contact a case manager to help when applicable. So if the member has a case manager, they're going to reach out and ask for help. Say, hey, we received this referral. We haven't been able to get in touch with them. Can you help us get in touch with them? They will attempt twice per day for 5 business days before they close the referral. So they will be calling multiple times a day for 5 days to try to make that initial contact. An incomplete referral letter will be sent to any member when a referral is closed. So if a referral is made and Telgen is not able to make contact, they will then mail a letter so that the member knows what happened and a new referral can actually start and the process will start over. Next slide, please. Okay, so what is some of the information that is necessary for members to know for the intake call? They're going to need to know their availability for an assessment within the next week, including the availability of your desired participants. So if Telgen contacts me to do an assessment, I need to know when I'm available in the next week. And if I would like Cassie to be at my assessment with me, I also need to know if she's available during that week and what timeframes she's available. Current services in place, and then any recent changes to their health or functioning. So any recent falls, hospitalizations, new diagnoses, overall medical conditions and medications. This gives the vendor a way to put some basic information into the system for the nurse assessor to come out and be able to conduct a full, complete assessment. It gives them a starting point. Also, how they are going to assess and determine, as we'll get into the next processes here, around whether something needs to be expedited, things like that. So these are some key questions and some key information that is going to be necessary for the intake call. Sorry. Okay, next slide, please. Okay, so here is the proposal for the intake call criteria. It's very wordy, and my apologies, but it's important to make sure we got all this information in here. So the intake staff or the nurse assessor will do a pre-screening of the referral request in order to confirm the completeness and validate the submitted information. So the information that is submitted during the referral, they're going to go through that with the member to make sure the information is accurate and get as much information as possible. They are all screened, all the referrals are screened to ensure that necessary documentation is available before scheduling. They are going to be looking for the assessment type, whether it's a change in condition. So the member has services and needs a change in their services, and therefore it'd be a change in their condition, whether it needs to be an express review. They are going to be verifying that during the intake. The assessment urgency may include recent changes in condition, new diagnoses, or medical history updates. So the urgency of the assessment may shift based off of those factors. Documentation is requested as part of the intake and screening process. It is not mandated, it's not required, but it sure is helpful. It will better help the vendor be able to determine the type of assessment that is necessary and the urgency of the assessment. Referrals will then be routed to the scheduling team as needed, and referrals will not be rejected based solely on information provided during the screening. So to be clear, a referral is not rejected just based off the information that comes in the screening. Questions on that? Cassie, do you want to walk through a few? If there are any.
There are really no questions specific to this at this point.
Is there anything that you would like us to go back to or just keep moving?
Yeah, there was hold tight, Megan. Let me add, I think there was a good question. If an assessment was completed already for another home health agency, and then a different home health agency gets a referral for the same client for the same services, like, will they share that assessment? Does it need to be duplicated? How can they kind of work together if a member chooses to switch from one home health agency to another?
That is a great question. They will not need to complete a whole brand new assessment. So I'm having trouble seeing. I think Katie came off mute. I had so many comments coming up, I couldn't see your screen anymore. They won't need to complete a new assessment, but I'll let Katie jump in as she manages the contract and knows all of the things there.
Yeah, thanks, Candace. So think of it as the member owns the recommendation. So Telegen will outreach the member and ask them, we received another referral from a secondary home health agency. What would you like us to do? And chances are the member will say, I want it shared with both. So it just depends. And then I can see that situation also creating what we talked about before, kind of duplicative referrals. So in that case, the same applies to what Candace said. One assessment can be done and then shared with both, but that is ultimately up to the member to decide.
Thank you, Katie. Cassie, are there any others you want to get to it, or should we go to?
One more, I think, is what if Telegen reject a referral? What if you get screened out? And is there a difference between like incomplete versus just a downright rejection?
Good question. I'm going to punt that one over to Katie as well from a contract perspective.
So the scenarios that I can think of, an incomplete means someone who has gotten past the screening process. So meaning they have Health First Colorado, it appears that they would be eligible for one of or multiple combinations of this service. And incomplete literally means they didn't submit like the contact information. So Telegen had difficulty completing the process of making contact with that member to complete the assessment. So that would be the one scenario that I would think of for that. Rejection is, I don't know that we use the verbiage rejection. Is that in the contract, or did someone use that word?
I think that was a question that came in is around a rejection. Really, the only way that they would reject a referral is for somebody that isn't actually a Health First Colorado recipient.
Correct.
And that to the Tara's question here in the chat, are they going to proceed if they don't have long-term care? They don't have to be on like waiver eligible, for example. They just have to be Health First Colorado eligible.
Correct.
All right. I think we can turn to the phone.
Or the virtual computer.
The virtual hands, I should say.
I see a face. Let's go with Megan. Hi, Megan.
Hello, good morning. Yeah, it's morning.
It is Megan. Hi,
two pieces, yeah, yes. Two pieces with that. One is, so you have somebody who's newly applying for Medicaid, will not be eligible for Magi buy-in, needs a waiver in order to be eligible. Part of that process is, so there's the actual waiver eligibility, and then there's the par for services, and there's often a bit of a delay between that. But usually a case manager is working with them to develop their service plan for their waiver to prepare for that before they're actually Medicaid eligible, because of how that, if they can only be eligible for Medicaid through a waiver for kids in particular. So in that case, is there any way they can get their skilled nurse assessor process done prior to them actually having Medicaid eligibility? Because otherwise they're going to end up with a delay, like an unnecessary delay in services to just jump through the paperwork hoops.
Yes. Great point. And I'm phoning a friend. I'm looking to see if anybody's responding. But there's a current process now. I know when it comes to skilled care services, there's like some sort of letter, and nobody's jumping in. So we will have to take that one back to get the actual exact process, Megan. I see exactly what you mean. I know what you're talking about. Let us work on that exact process and that flow for those specific scenarios and cases, and make sure, one, that it's in the training, two, that it's online, all of the things as we move forward.
Awesome. And then my other question was just about the amount of documentation and what that documentation actually looks like for the intake call and all of that processes. I think right now the home health agencies take on like 99% of the burden of collecting documentation for all of this process. And I'm concerned about a lot of that falling on the member.
Yeah, so great question. It's not required to fall on the member. It's really, what do you have? So if you have a lot of information, medical records, I think about, in a situation where you are the primary caregiver, you typically, especially over years, have acquired quite a bit of information, and you can provide all of that. The home health agency, if they are submitting a referral, they will also have that documentation that they will submit. There is no, list, you must have these three things. It is what you have, please provide, as it will be helpful moving forward. Does that make sense?
It does. I just worry that the process will then get biased towards those who are more able to provide documentation will be more likely to get a good assessment, and those that are not will be less.
The assessment is a very clinical, like whole body assessment. That will not be biased one way or another based off of a piece of paper. It's going to be based off of actual like body systems and things like that. So it's not going to be biased that way, but I can tell you that if for some reason something is missed, but the home health agency has some documentation to support that was missed, that can be included in their request, and will be part of the full medical necessity review and evaluation, all of it together.
Gotcha. It just feels like the documentation is great, provide it, and documentation is totally not necessary. And how can
Yeah,
it?
I mean,
and
other
then-
option is to require it, and then people don't have it. You know what I mean? So there has to be a middle ground, and that's what we're trying to do.
Fair enough.
Yeah.
Thanks.
All right. I have, I can't see. Susan, you have your hand up.
Yeah, so I just have a question. So when an assessment is done for another agency, let's say for CNA services, and then 3 months later, they're coming to your agency, that assessment doesn't follow, like there's not a time span where that assessment will follow them, say for 6 or 8 months, where a new one, what doesn't need to be done, I heard you, where they would then tell the member, do you want to do a new assessment or do you want that assessment to follow to this agency? Correct? They have that choice to have a new one done, or we would then get that documentation sent to us from the old assessment. Is that correct?
Yeah, if they have a change in their needs, they could get a new one done, for sure. But the assessment is actually really, they're good for about a year, like up to a year.
Okay.
And so, you know, they are the members. Every member gets a copy of their own recommendation letter, so they will have that information to provide to the new provider when submitting a new request, prior authorization request. And so a new one won't be necessary. They will have that information. You can always reach out to Telgen. They can provide the one if it was 6 months ago as well.
Okay. And then also too, when you're saying that you would want us to submit referrals 60 days prior to the auth expiring, and that's for obviously an auth that we already have, in
Correct.
the works. That's
Correct.
for the assessor to have that 60 days to do that assessment. And then of course we would still be requesting our auth within the time period and having the documentation within the period that we needed it.
Yeah,
That
so
gives-
they don't get 60 days to do the assessment.
Yeah.
They get 9. And really what it does is it allows the opportunity for that process to be completed, and you still have the majority of your time to complete the plan of care, get the physician letters, the doctor's orders, all of the things that you need, and still submit the prior authorization request in time. And to your point, yes, it is for those that already exist. For those where you don't currently have a prior authorization, that's where the process comes in, where we have asked for 15% each month to be submitted based off of your own agency's determination of how you want to submit those in that flow.
Okay. All right. Thank you. Appreciate it.
Yeah, of course. Great questions. I see Katie has her hand up, and so I'm going to call.
Candace, I wanted to jump in just for really quick. Susan asked great questions. And to that point, we opened up that window to 60 days because this is a new process here in Colorado. And so we want to allow lots of time and cushion for you guys to figure out your processes at your agencies. And then second, Susan, to your point, Candace touched on the changing condition and express assessments. And then there's a couple other types of assessments that are going to be available too. We're getting ready to release the criteria that is required for those assessments, and that will help answer some of your questions too. So more to come on those. This is just, broad overview of those assessments. So we're going to be providing what you're asking for in a very detailed way in the coming weeks.
Exactly. And we are finalizing that criteria right now with your feedback today. And then it will be line by line, extremely detailed, all available online, and will be provided in trainings, which will also be posted online, just to be clear. So everybody has all that information. Thank you, Katie. All right, Tara, I know your hand was up and then it went down and then it went back up. So I'm gonna go ahead and call on you if that's all right.
Yeah, I pressed the wrong button. So I kind of have like a dual question, kind of to what Megan was saying. When we go to do our assessments, let's just say we're going to do a PAT, we don't complete our narratives or determine potential hours of service until we have all supported documentation. Our nurses can go into a home, a parent can say, yes, the child does this, or I do this, this, and this. But if we don't have the supported documentation to back that up, we're not going to provide hours for that support. And what I heard is that the assessors are not going to be determining whether they qualify based off of the supported documentation because they're going to be looking at the function.
So what they're going to be doing is they are going to be conducting a acuity assessment that has attached, that will spit out, if you will, because I don't have a better way of phrasing it, that was created that will produce the number of recommended hours of care for that individual. Yes, the nurse will look at the documentation if it exists and if it's there, because it's helpful for a nurse to have background information, but they are conducting the assessment based off of the member's needs and the responses. They're going through the whole body system, like all the different body systems, to determine what interventions are necessary. That then produces an actual number at the end of the assessment, whether it's 10 hours a day, 2 hours a day, 15 hours a day, whatever it is, it produces a number based off of that assessment, which is conducted by a clinical professional who understands the body systems and how it works, that will then be produced into a recommendation letter. So then from there, that recommendation letter goes to the member. If there's a provider involved, to the provider as well. The provider is still responsible for creating the plan of care, getting physician's orders, all of those pieces, all the appropriate documentation necessary in order to then determine, okay, based off of this recommendation, based off of all of this information, the physician's orders, the plan of care, here is how we are going to meet that member's needs. And if it doesn't match the recommendation letter and you have the documentation showing exactly why, that's fine. You submit it and all of it is looked at as a whole. This is the beginning piece that will be conducted for each individual, and then the agencies put it all together to formulate and produce a prior authorization request for how many hours they are going to staff this individual at the various levels.
Okay. And then the secondary question is that kind of going back to the Medicaid piece, that yes, they have to have Medicaid in order to go through this. However, Magi will only cover the acute period for, let's say, parent CNA or any CNA services. So if they're in the process of trying to get the long-term care, but they haven't necessarily been guided down that route, let's say I'm not the one that sends them the referral and gives them that information. Typically now we only say that our PATs are good for 30 days and we always redo them after the 30 days. So after that acute period expires and they still don't have long-term care Medicaid, is another assessment going to be completed to ensure that the level of care is still the same, or are they just going to go off of the initial recommendation?
That's a good question that I'm not sure that we have formulated a process step-by-step on how that will work. So let me take that one back so that we can work through that piece as well, because for those that have the acute and then it's extended, let us talk through that a little bit.
Perfect. Thank you.
Yeah, great question. Okay, so I know we have a couple of hands raised. However, I have a lot of slides still to go through. And it's really, really important that we get through them because some of these are ones that I desperately would like your feedback on. So if you have a question, please go ahead and submit it into the chat. That way we can have it documented and hopefully we can get back to it today. If not, we will for sure get back to it when we post everything online. Okay, next slide, please. Step 3 of the process, we've made it to the third step, is the assessment. So assessments may be done in person or virtually. And virtually means like how you can see my face now, virtually. There are 2 timeframes in which the assessment must be completed. Standard, so within 7 business days of the referral. Again, a member may request a little bit lengthier time. So there's like a little asterisk there, but Telgen may not extend that timeline without the request of the member. Or expedited, which is within 72 hours of the referral. And an express assessment can be done every other year if there are no changes of condition or services. We're going to go through that a little bit more in the next coming slides. So hold on your questions on that because we have a lot more information around express assessments coming up. All right, next slide, please. All right, feedback request. Okay, so this is really important. Here is what we are looking at. And I really, really, really need you all to take a look at this and provide us some feedback. In-person versus virtual criteria. So as referrals come in, an intake call is conducted, Telgen has very specific criteria that they are going to be following to determine if somebody must be an in-person assessment or can be a virtual assessment. We are finalizing that, and this is where we're looking for your feedback so we can finalize that criteria that they must follow. So nurse assessors will use clinical judgment. So this is a draft. This is in progress. I want to be clear. Here's our recommendation. Here's where we're starting, and we would like your feedback on this particular language and these components here. So they'll have to use their clinical judgment to determine if in-person assessment is appropriate or not, based off of all the information available. All requests for in-person home visit assessments will be reviewed and screened to determine if the referral meets the criteria. So some examples of those that would be routed to in-person would be technology constraints. So the member lacks access or ability to use the required technology. So if somebody doesn't have the ability to do a virtual assessment, they will need an in-person assessment. Complex or high-risk cases. So when there's multiple conditions, high utilization, or it's unclear what the home interventions are, an in-person assessment would be recommended. Caregiver support. So the assessment needed to evaluate the family member or caregiver's ability to provide all of that support and how much additional support is necessary. Mobility limitations, so perhaps physical observation is necessary to assess function and accessibility. Next slide, please, because it's continued on here. Preference and appropriateness, so member preference and clinical need, communication barriers, some behavioral needs, so perhaps in-person visits are necessary because you really need to build that trust and assess a person's emotional well-being, information gaps. Is somebody new to services or a changing condition? These are the current outlined criteria for determining in-person versus virtual. I would like to hear some thoughts on this criteria from folks. Cassie, is there any feedback thus far in the chat around this criteria?
There is a comment or about the concern of family caregiver being assessed for capability. That's a new thing. How will they do that? What does that really mean? That was the comment.
Yeah, it's really about ensuring that if there is 24/7 care, you don't have one person only doing the care, right? So one person, it doesn't matter who you are, you have to sleep. You cannot provide 24/7 care all the time, every day, for the next 15 years. Your body will shut down. And so really it's ensuring that the amount of care that can be provided is realistic and ensuring that they have the totality of the services and the needs documented within the assessment. And again, this is a draft, so we are looking for feedback. There's a lot of hands raised. I'm going to go to some hands because I skipped a bunch of you last time. Arthur.
Great, thank you. Once again, I think this is one of those scenarios, right, where we don't want this assessment to be a barrier to care. And I think your point about the acute episode, I think kind of allows us to provide care during that 60-day time period, which I love. But I think so much, especially on the complex clients, right, going out to the home and seeing their environment, seeing how the care is being provided. I think you do the patient a disservice if it's not in person to really understand their medical condition, all the moving parts, what, in some of these homes, right, the access to different things, whether it's a bathtub, whether it's, their ability to move throughout the house. I think those things are important to really understanding the needs of the client and the ability for that client to get care. So I would suggest in scenarios where you have patients who are receiving long-term care, that there needs to be an in-person visit. I like the concept of it doesn't have to be every year if nothing's changed, you've been out there. But I think also the question I have is in scenarios where there are multiple clients receiving care, like, is there a way to have it all done at one time so that you're not going out 6 times to see all 6 patients and disrupting kind of the home environment? So any thoughts on that as well? But I love the in-person. Everybody should have an in-person sometime in that process.
Appreciate it. And thank you for that feedback very much. We appreciate it. And then around your question, if there are multiple members within the home, can they go out once versus multiple times? I think that's a really great question and a really great point, and something that would be better for everybody, including the vendor. And so we can take that back and see how we can make that a reality, because it just makes sense. It just does. So thank you for that feedback. All right, next in line with their hand raised is Irina.
Hi, and thank you, Arthur, for your comments as well. I think that's very important, potentially considering if it's possible to have at least initial assessment in person. But a couple of other things I wanted to mention. So just again, coming from the home health perspective and telehealth and everything, I think we should have an option.
Irina, we have somebody that isn't muted. If you could please mute yourself so that we can all have the same opportunity to hear Irina's question, I would appreciate it. Sorry for that, Irina. I just
no worries at all. What I wanted to suggest is also having an option, for a client or a member to choose if they want to opt out from the telehealth and choose an in-person. That is a potential as well, kind of promoting their rights with that as well. Also, towards what Arthur mentioned, maybe including the frequency or the level of current services as a criteria. If we have quite an extensive combination of services, maybe both, HMA and skilled involved together, that could be a criteria of a, complex patient. And I know you've mentioned a high-risk complexity patient, in your earlier slide, maybe specifying that to a certain group of diagnosis that could be a trigger, like certain, primary diagnosis of comorbidity, as well. And I'm sorry, I'm now throwing lots of things at you.
But this is great. This is exactly what we're looking for, so I appreciate it.
And then maybe just if it's possible to get this information accurately, the number of recent hospitalizations, or maybe like a recent hospitalizations, to capture that, or transition from a nursing facility, something like that, to include it. And again, as a thought, to maybe aligning the referral screening with this criteria, where the whoever does the screening on the nurse assessor side, maybe their referral screening produces all these questions that at the end, sort of like it spits out the number of hours from the assessment, kind of meets criteria for in-person versus meets criteria for, telehealth. Again, just a thought.
Yeah, those are great. Thank you so much for that feedback.
While I have your attention, just one quick question. I know you've mentioned, technology literacy and cultural component, including language barrier, which is huge, right? I'd say so many providers on the call today will have such a diverse population that we are serving. Will the translation services will be available for in-person or telehealth assessments?
So I'm looking. So I know somebody could certainly bring somebody to help them with translation, because they're welcome to bring whomever they would like. And so
if there's not a family member, or somebody's not fluent, just to make sure we don't miss the valuable information in the assessment because of the language barrier.
Candace, can I help you answer that one?
Yes, please. I was looking for that in the chat. I was like, somebody had to have answered this.
So access is a huge focus for our Help First Colorado members. So, but I know that's also a service that a lot of home health agencies offer their members too. So it's literally a preference of the patient. If they work really well with their home health agency, and their home health agency has some type of telelanguage service that they've been using to communicate and work with this member, they're more than welcome to utilize that service for the assessment. But if they aren't, and that's a barrier that they've been facing, HICPUF also has some resources that they can utilize to help provide some relief to that language barrier. And we'll go ahead, we'll provide that information on the website and in the trainings, so that you guys have it readily available if that ends up being a resource that you would like to utilize.
Thank you, Katie. That's super helpful. All right, we have a lot of hands raised, and I still have a lot more. Thank you, Irina. We still have a lot more feedback to get from you all. So thank you so much for all of that. That is really, really helpful. I'm very happy we're recording this so that we captured all of that. Next up is Katie Wallet.
Can you all hear me okay?
We can. Thanks, Katie.
Wonderful. I just had a couple process questions just to better understand what we're going to do with the feedback that we're providing. I understand from the contract that Telegen is required to come up with this criteria, and then I think the department approves it.
Mhm.
So I think my first question is, I'm assuming that the feedback that we're giving you, then the department can sort of incorporate into the criteria.
Correct.
Okay, and then where will that criteria live? I'm wondering about like what someone would do if they determined that in their case the criteria wasn't followed properly because somebody from Telegen, the intake person, made a mistake, right? So like if I'm a case manager, do I have this criteria available to me and the ability to say, wait a minute, actually this person definitely needs to be in person assessed, and the intake person sort of made a mistake? Like how will that look if there's those sorts of complaints or like something that's not working?
Sure. So, the criteria will for sure be available online. It's going to be part of the training. If somebody feels like something was missed, we will have a process for, I don't know if it grievance or complaint or something along those lines. I don't know if those terms are quite accurate here, for somebody to reach out so that we can get that corrected and make sure that the process was followed or corrected if it wasn't followed appropriately, things like that. So we are creating that process as well, and that will be available online to folks. We will make sure case managers have that as well, home health agencies, everybody will have access to all of that information. And it will all be online in trainings, all of the places.
Yeah, I would, of course, definitely recommend that the complaint process live and rule if at all possible. And we would also love to be able to provide feedback on that complaint process, just because we know things pop up. And we need some way to be able to say, hey, wait a minute, this isn't going the way it's supposed to be going.
Yeah, that sounds great. Thank you. All right, Sherry.
Thank you, Candace. So my question is, I agree with what's been said previously. My concern is that what you have so far for like a patient with complex needs is pretty subjective. Even with nurses between us in historically, we come up with different opinions, what's complex, what's not, what's comorbid, what's not. I think we need to have it a little bit better defined because, Telegen historically needs that direction. And so I'm concerned with that. And then the second part of that is really how are you going to, make it different? I mean, currently home health and IHSS, we have to go do our intake assessment in person. So if it's a brand new intake, it seems like that needs to be in person. If the nurse assessor is the first person, the first skilled person to get eyes on that home and that patient, that client, they need to see what that's like in order to better define where it's going from there. And I think I speak for a lot of the chat. A lot of my cohorts are saying the same thing. So that would be my recommendation. And if there's not changes, including like if there's a change in condition, that would be another one that should be in person, because we need to see what is it. If we do it currently, if that client has a change in condition, we're out there doing it to see what's different and what's the new equipment, what does it look like, all of those kinds of things.
So I'm hearing a lot of feedback that all initials should be in person, and then really specifying what it looks like to be complex from diagnoses, like really making that super, super clear. If you have specific ways that you think would make sense to define that, you want to provide that information maybe in writing in the chat, that would be super helpful. So thank you so much for that feedback. I'm going to take one more and then move on because we do have more slides. And I only have 30 more minutes with you all. And so I want to make sure that we get through all of the information. Today is not the only day to provide feedback, just to be clear. So let's see here. Next, I'm going to go to, and Megan, my apologies, but I'm going to jump to Laura because I have not heard from Laura yet. And I have heard from you and from Tara, which please continue to provide feedback and raise your hand and jump in though. Laura, please go ahead.
Thank you. I appreciate that. And I apologize to those that I jumped over. But I am thankful because mine actually has a lot to do with what we were just talking about. Arthur brought it up. And so in regards to like classifying somebody as like a changing condition, I think we need to have some criteria there as well. Like we're talking about with the different understandings of what people can define. I have seen, speaking from, the provider perspective, that when
client is asked, hey, have you had any changes in condition? In their mind, they haven't, because they're thinking about like, hey, today or yesterday or within the last month, but it doesn't necessarily mean that they haven't had like a significant change in condition for the period of time that that person that is asking them is thinking about. And so if there's not more in-depth questions asked at that time to determine, yes, there's been a change in condition, then that question is going to be like, oh, no changes in condition. And if they're not going to the providers or the person that's doing it, like the caregivers, and saying, is it taking longer to get them up and down and in and out, and all of those questions that the client might not be thinking about when they're asked, do they have a change in condition? I just think we need to maybe discuss what that criteria looks like and make sure that it's a part of those questions that are being asked, to help determine if we should go out and see them or if there's actually more hours needed.
Yeah, great points. And so that's one of those key things, right? Whenever you're conducting an assessment, whether it's a clinical skilled care assessment or not, I know from the history of going out and conducting 100.2s, because I used to do that. They're really specific. There's ways to get information, and there's ways to not get information, right? And it's about how you ask those questions and which questions are being asked. And those are things that we are actually working on to help with, here's some prompting questions like, is this taking longer? Do you have to do this more frequently? So there's some really key areas that we want to make sure that Telegen is focusing in on, and we are working through that, and that will be part of the training and all of the pieces as well. But that's a really great point. If you have specific things and specific ways that you want us to define changing condition, if you could submit that information, so that we can take a look at that and see how we can incorporate that, that would be really helpful. So I'm going to move us forward so that we can make it through this slide deck today. Next slide, please. And to be clear, I want you all to continue to think about that criteria and provide the feedback on what that looks like. Okay, so the next one is expedited assessment criteria. So urgent assessments are prioritized when an immediate risk or needs are identified. Expedited assessment referrals will be screened, ensuring that they meet the established criteria. So again, here is suggested for expedited criteria. Acute medical conditions, so sudden or severe health decline, high risk conditions, social risks, caregiver crisis, unsafe environment, time sensitive needs. So again, these will follow a different timeline for getting the assessment completed, and we are looking to you all to help us finalize this criteria that Telegen will use going forward. I think the next slide, let's go to the next slide as well, just because it has a little bit more information on it. The intake nurse assessor will triage/screen all expedited assessment referrals. So basically they will go through this and use this criteria to screen, to determine the urgency based off of that criteria. Expedited assessments will be scheduled as soon as possible within 24 hours of receipt of the referral and conducted within 72 hours. So let's go back one slide just so folks can see the list here. Thank you so much, Paul. All right, thoughts on this criteria as is. Now, keep in mind, these are super high level. As I've heard from you all on the past one, on the previous one, we need to define them and broaden them and expand them a little bit more. Great feedback. What other pieces, are there any other categories that you all feel is missed specific to the expedited assessment criteria? Alicia.
Hello. Hi. I see what you're talking about for like the expedited assessment criteria, which I think is great. I'm just looking more at like the urgent medical or resource access needed. I feel like there just needs to be an even deeper definition of what that is, because we each have our own definition of what is urgent medical. It's like we have a lot of individuals on hospice, or we have a large unhoused population. So I do feel like maybe that needs to be a more intense or more clear definition of what
Defined
is
a little bit
time
more.
sensitive.
Okay. If you have any suggestions on how you would define that, we would love to hear it. You can, put it in the chat, or we're actually going to have a feedback form that we'd love to hear from folks too, so that we can take a look and understand how other people are thinking about it. That would be super helpful.
For sure.
Thanks, Alicia. One thing I miss, individuals that are looking to discharge would fall into this category as well, just to be clear, so that people understand that. Other thoughts or questions or feedback that you all have around this proposed criteria for expedited assessments? I'm glad that we're going to get a lot of feedback on the in-person versus virtual, but I'm hoping we get some on this one as well. I know you all had a lot of thoughts on that, which is helpful. Cassie, is there anything in the chat specific to this that we could cover?
Well, it is very subjective. That is a fair statement.
We're doing our best, and that's why we're asking for some feedback, but we're doing our best to kind of define some of this.
We'll go ahead and we can take to the calls. There's not really anything too specific.
Okay, great. All right. Katie.
Hi, thanks. I was just curious. I'm sorry to be so process oriented, but when I think about someone asking about an unsafe environment, that like raises all kinds of red flags just in terms of like being able to identify that I'm being in an abuse situation or neglect situation and all the safety things that come from that. Can you help us understand when we talk about this criteria, who then drafts the questions and the way that those questions will be posed? Just because we've been saying, and you just said earlier, how important the way these things are asked is. So I would just love more information about that, because I could certainly imagine someone who is in an unsafe environment who cannot identify that. And I'm just curious about how that would look.
Yeah, obviously that's not a fail-safe, right? They're not going to 100% be able to identify every single unsafe environment in no way, shape, or form, because not everybody's going to be able to identify their own environment completely. This information could come from the referral source. So for example, a case manager or a home health agency is worried about the home environment, they can add that into when they submit their referral. As far as the specific questions that are going to be asked, Telegen and the department will identify those questions in that flow and what that looks like. Some of them are pretty straightforward, how often, how frequent, things like that. Some of them are going to require a little bit more nuance, and will definitely have to be an in the moment call. We can't script out everything because every single person is different, nor are we going to script out everything. We are going to rely on our experts in the field to use their clinical judgment to be able to determine their question flow. We don't script out case managers' assessments and their service planning process word for word. We're not going to do that for the nurse assessor either. But there will be some prompts and some cues and some things that we can go through and develop with Telegen directly. Arthur.
Yeah, so I think the criteria you have here is actually pretty good. I mean, I suggest that in scenarios where we can use an acute episode and none of these apply, right? Just a new client who needs services but doesn't fall into obviously these areas. I don't think there's any need to make them, an expedited assessment. That would take away from those who need it. I would suggest though that all PDN clients be expedited, right? Because that's a scenario where we can't use the acute episode. And because of the high acuity, like they need the care, they need it right away. And we don't want to put the agency at risk at trying to guess at what hours will be approved. Like, do they qualify for 12 hours a day? Do they get 24? So I think I would probably automatically make all PDN referrals an expedited assessment.
Real quick, Katie, I see your hand. Can I clarify, you would recommend all new PDN referrals to be expedited? Because for those that already have care in place, the PAR is there, all the things, right? And so just to clarify, you're recommending new ones?
Yeah, exactly. Okay. I mean, once again, if they're ongoing, if it's someone who's currently getting care, I still think they should have an in-person assessment, but there's no reason to make that expedited because they have access to care, they're getting care that's been prior approved. But new clients, absolutely, you got it.
Okay, thank you for that feedback. Katie, go right ahead.
Arthur, we hear you. That was definitely one of the very first scenarios that we thought of, that the expedited assessment is kind of built around that concept. So just so you guys know, in addition to like your stakeholder group, we're also doing similar training with discharge planners and case managers in the hospital setting for those exact patients that you're talking about, those initial potential PDN patients. So thank you. But yes, we did think of that.
Thanks, Katie. And again, thank you for that feedback, Arthur. It's super helpful. Tara.
Hey, okay, so I remember, Candace, you saying in a previous meeting, and I don't remember honestly if it was a CDAC meeting or if it was the nurse assessor meeting, it was one of the two, where you said that you guys don't want to delay care. Like, we don't want to do that. So if we get a referral from a hospital and within 24 to 48 hours, we're admitting into our agency for PDN, RN, CNA, whatever it might be, what does that look like when we go to get the PAR intermittently while we're waiting for the assessment to be completed?
So to your point, if somebody's in the hospital, they are going to fall under the definition of expedited assessment. And we can go back to the other slide, Paul, the next one, where the assessment is actually completed within 72 hours. And so there will not be a long time span between when that assessment is completed. And then you have that 10 days for the PAR in order, and you will have this recommendation long before that 10 days is up. And so this isn't going to cause a delay in that care. If there is a specific scenario that we want to walk through, we can certainly do that probably offline because I'm almost out of time and I have more slides. But we can certainly walk through that so that we can make sure that we have appropriately evaluated those scenarios and we can train on those as well.
So are they planning to do these assessments before discharge?
Yes.
Okay.
Potentially. Perfect. All right. Let's go to the next slide. We'll move on because there's no current hands up, not saying that there's not more questions. But we're going to keep us moving here today. So express review, as I mentioned in the previous slide, an express review can be conducted if an assessment was completed for a member within the last year, and there's been no changes in the member's functioning or service needs since the last assessment. This is only for adult members. Pediatrics, children in general, change far too quickly. And so this only applies to adults. This is similar to the process, I want to kind of put it in line, that is currently used when you're talking health maintenance activities now, and how we can do an express review through Telegen. The same idea where we could do an express review for members on long-term home health, PDN, or health maintenance activities when there has been no change since the last assessment. Adult means 21 and over. All right, next slide, please. Okay, so the recommendation letter, step 4. This is the final step of this process, is the recommendation letter. This is the output of the assessment. This will be available within 2 business days from when the assessment is completed. So once the assessment is complete, the recommendation letter is out to the member and available within 2 days. The member will be notified that the letter is ready in the user portal. If the member prefers to have it mailed, they absolutely can have that, and it will be mailed to them directly. The letter is uploaded to the user portal and shared with whomever the member has requested for it to be shared with during the referral or the assessment process. Case management agency, home health agency, whoever it is that was requested to have a copy of this letter within the portal, it will be shared with that individual entity, agency, whomever it would be. And that is available within 2 days, 2 business days of the assessment completed. It is not the FMS portal. The FMSs are different vendors. So fiscal management system, that's for consumer directed attendance support. Sorry, I saw that question pop up and I just answered it. This is Telegen, completely different vendor. They have their own portal. So it's a different system itself. Because not everybody utilizes the FMS, especially not long-term home health or private duty nursing members. Okay. Next slide. We have time for a few more questions before we move into next meeting and kind of what to expect from here. So I'd love to answer a few more questions for probably about the next 5 to 8 minutes. All right, Sherry, you have your hand up.
Thank you. So what is included in the recommendation letter? Are they going to have details of what is being approved or recommended? Is it going to include the skilled acuity tool? Is that acuity tool going to go to the case manager and to the agency so we know where that's coming from? Could you speak to the recommendation letter?
So the recommendation letter is going to have the breakout of the recommended hours by the level of service. So recommended based off of the acuity tool that you get 6 hours a day of nursing care and 4 hours a day of CNA. And if they've done the direct care calculator because they've identified unskilled needs, then you also have, 7 hours a week of homemaker services identified, whatever, making up numbers and services, obviously. So it will have those details in there, broken out by the service type for the member as identified within the assessment.
Where's HMA going to be defined though?
It will be in the recommendation letter as well.
Okay.
Yep, all of that will be in the recommendation letter. I do know that there's also some questions about how folks can appeal this process. This is not an appealable process because this is not a determination of services. This is only a recommendation. The appeals process will follow the same flow that it always has. It will be at the same point it always has been. This is not changing that. This is only a recommendation. This is not an eligibility. This is not a determination. This is not an adverse action in any way, shape, or form. If the member wants to appeal the services that are submitted for a prior authorization, at that point, they will receive all of their appeal rights and absolutely 100% are able to appeal their services at that time. So just want to make sure that's clear that the appeal timeframe is at the exact same point it is now. It is during the either reduction or denial of the services. And this is not a reduction or a denial of the services. This is only a recommendation. Okay. Katie, did you want to add to that or something different?
To your previous point, actually, Candace, when people are asking about what is the recommendation letter going to say about the services, in the off chance that the assessment produces that there are no skilled needs, it will also state that.
Thank you so much, Katie. That's helpful. An important piece that I missed. All right. Bushra, we have you next with your hand up.
Yes, thank you so much. My question is for ongoing care. A majority of the time, sometimes we have patients or caregivers who don't approve with the assessment or the hours and would like to be reevaluated, but they're not at their par at that time. During that ongoing care, would they have to go through the whole process over again in order to be evaluated for hours? If they want to go out and say, we want to be reassessed and be reassessed again, what would that process look like?
Great question. So Katie, I'm going to ask you to jump in because this will be from the intelligence standpoint. But what does that process look like for somebody who's requesting to be reevaluated without a change in condition is what it sounds like.
Yes, exactly.
Correct. So at this point in time, we don't have an opportunity for reassessment unless there is a change in condition or change of the PAR that the recommendation will help inform. And then to some of the other questions in the chat, Intelligent will not be coming to appeals hearings. The skilled care acuity assessment results could potentially be used in an appeals hearing, but we will not be having staff from Intelligent be represented at appeals hearings for the then PAR that Accentra manages. I just want to make sure that Candace was 100. I thought she did a great job distinguishing the two very different processes.
Okay.
Thank you, Katie.
I had one more follow-up question.
Sure.
We have a caseload per nurse assessor at this time. I know a lot of us in the chat have been, dealing with the case management agencies. We do get a timeline, but depending on how many people we have in the office, how fast we can get those referrals out. One, are we going to be able to really stick to this timeline? And two, do we know what the caseload will be per nurse assessor? That's okay.
Candace, do you want
My computer does this thing where it mutes me in, like within the system. I have to go into my sound settings. It's so lovely.
You're fine.
So apologies on that. So we don't have a caseload or a requirement for Telligent. We did not build that in because one, it's not an ongoing caseload. So the difference between a case management agency and Telligent is, for example, case managers have an ongoing caseload. They have these members that they support ongoing, where they continue to provide support. They continue to make phone calls. They continue to help them with resources, check in on services, things like that. The Telligent is just the assessment. It's just the assessment. And it is not you have 15 assessments per day to do, because that's not realistic. Every member is different, and the assessment is going to take a different amount of time for each member. And so there is no caseload because they don't carry caseloads. It's how many assessments are they going to complete. They will be held to those. There are contractual requirements. There's deliverables, payments, all of the things. We will be monitoring that extremely closely. I won't even say for the first year, because it's actually forever that we will be monitoring that to make sure that they are staying up to date. Okay, so I want to keep moving because we have a few more questions, and I want to make sure that we get to my last couple of slides. Molly, I think you were next.
Thanks, Candace. I'm sorry if I misheard, but if the recommendation is only has the breakout of hours, how would a member, in speaking with their case manager, how would they provide additional information? Let's say hygiene is, some of it's skilled, some of it's unskilled. If they don't know what each of those categories is being allocated or recommended by the nurse assessor, how do they know to go to their case manager and say, hey, I think the nurse assessor missed it in this particular task or this area, if they don't have the details of that assessment and what's being allocated in each of those categories? How do they have any information to actually contest that?
Yeah, understood. That's a great question. And so the suggestion is to make sure that we have the details available to the member so that they can work directly with the case manager. And that is something that we can certainly ensure, whether it's the assessment itself or it's added into the recommendation letter. So yeah, great feedback. Thank you very much.
All right, thank you.
Bryce.
Yes, hi, can you hear me?
Yes, we can.
Okay, I have a question just about, I put this in the chat too, just about communication channels. So we do have a separation, right, between the assessors and that whole assessment process, and then when the case managers enter the process. So they're going to be receiving the recommendation letters along with the member. At that point, after the assessment has been done and after the letter has been generated, what are the communication channels? If you want to clarify something in the letter, can you get in contact with your specific assessor? Or would you have to call the call center, for example, for Telligent to get a clarification? Or would the case manager have more of a ability to communicate and clarify if you're advocating for increased hours? Especially with these initial intakes, I think that just the communication between and case managers is really important, and I'm not seeing that anywhere in guidance or in contract.
So there's not going to be an I think there's two pieces here. Is one, if they have a question specific to what something means, how do they get that answered? And then two, it is kind of how do they reach out to say, I don't think this is quite right, can we get this changed? And that's not going to be how that works. So they can't get the assessment changed or call to advocate for something to look different on the assessment. That is not going to be how it is. If there is something that is not accurately reflected in the assessment, it will be on the home health agency and the case management agency to show how it is not actually accurately reflected with documentation and justification that will be available. As far as questions, we can look at that and see how we can come up with a process and what that will look like going forward. I think that's a really great point. What if there's just a basic question about what something means? We can look into that. Katie, did you want to add to that?
Yeah, to that point, Candace, they will have Telligent has a customer service phone line. And then there'll be an email that people can access as well for technical questions like that.
Thank you, Katie. We already have that designed. Katie's got this.
In terms of the case managers, though, if they're trying to amend
Yeah, they could reach out to them that way too, and they can't amend the assessment. So just to be clear, the assessment
the
is not,
service plan,
they do that on their own though. They don't need the assessment amended in order to complete the service plan. And
right, yeah,
but if they have a specific question, they can also reach out to the customer service sector of Telligent as well. The case manager could directly.
okay, so it will be via the customer service.
Yes. All right. With that, we have 4 minutes left and I have a couple more slides. But I appreciate everybody asking questions, providing feedback. Can we go to the next slide, please? Just a little reminder, here is what the next couple of months are going to look like here. What month are we in? We are in May. So we're working on training for the vendor itself. We then starting next month could be busy. I want everybody to know next month is going to be busy. There is going to be a lot of things that are going to be happening, but it will all be online. It'll all be posted. Excuse me. So if you miss something, I totally understand. It's busy. Training for stakeholders, training for providers, training for case management agencies, system preparations, more Telligent trainings on the referral process and their system specifically. So there's going to be a lot of training that is going to be happening next month. So please bear with us. I know it's going to be a lot for your calendar, but please know it will all be posted online as well for you to review later if needed. July, everything is live, and case managers and the home health agencies can submit referrals. Assessments will be prioritized for members expiring sooner. We will also have office hours and continue education July and August and going forward for as long as necessary. We would like for you to continue to submit your feedback around the criteria that we outlined so that we can finalize this to get it over to Telligent so they are able to utilize this going forward. So we are going to need this feedback pretty quick because, as you know, July 1st is right around the corner. We created a sheet. I think my team is telling me they created a sheet, a Google form that they will post in the chat. Please feel free to use this form to submit your feedback around the criteria. Thank you, Erin. You also can submit via email, all of the things so that we can continue to get your feedback, take your suggestion so that we can make the changes, expand on things as necessary, and then we will post the finalized criteria online so everybody can see it. Everybody knows what the criteria is because it's very important that everybody knows what it is and going forward. Next slide, please. All right, our next meeting. So it will be in addition to all of those trainings I just talked about. So I sure hope you like my voice because you're going to hear it a lot. Just kidding. You'll be super sick of it by then. But it will be Tuesday, June 10th from 10:30 to 12. We will be covering a number of processes, finalizing things, making sure everybody has the resources that are necessary, making sure everybody has the appropriate contact information, how to submit a referral, all of the pieces, all of the things. We will be going over that on June 10th. Again, we are so grateful for your feedback. We're so grateful for your engagement, your willingness to come and look at all the information, provide some suggestions. Please continue to provide that feedback so that we can finalize it and make the best criteria possible. And with that, with 1 minute to spare, probably only a few seconds, thank you all so much for your time today. We really, really appreciate it. And I hope you have an excellent rest of your day. Take care.